being with us today. We're going to give everybody just a couple more minutes to get logged in, but in the meantime, I'll go over our couple little housekeeping items. The first is that, of course, we're recording today's session, so it can be shared later if you're not able to attend the entire session. We will have it on our YouTube channel later, or if you really enjoyed today's session and you want to share it with somebody else, we will have that available shortly after we get the recording processed. So definitely by the end of the week, check that out. If you would like to ask a question during today's presentation, you've got a couple options for that. You can use the chat function or the Q&A function, both of which you can find by hovering your mouse either at the top or the bottom of the screen, depending on which view mode you're in. And I will keep an eye on those and try to help moderate questions. Or we can hold verbal questions to the end, and you can use the raise hand function, and we can unmute your line and allow you to speak. But we just really appreciate Paul Miller's willingness to be with us today and present his great presentation to our whole group. We'll give it just about 30 more seconds, and then I'll turn it over to him to start today's Lunch and Learn. So thanks, everybody. Okay, well, as I said, we have today with us Paul Miller. He's the Division Chief of EMS for the Crawfordsville Fire Department, and he's got a great presentation put together for you. So, Paul, I'll go ahead and turn it over.
Thank you very much, and thank you very much for spending the next half hour to hour with me on the topic of quick response teams and working towards a recovery-oriented community. Now, since 2013, we have been collaborating with Franciscan Health to do just that, to construct one of the most advanced and progressive systems of care for the entire country, really, focusing on families and well-being and really creating a community that's more resilient and constructing health equity. So our platform with mobile integrated health and community paramedicine is all about creating social value alongside of economic development, and really operating on the fringes of public safety and public health for our community and the state as well. So in our community, just a quick little snapshot and background, we have fantastic leadership in Montgomery County with direct access to not only our governor's office, through our local officials, our state representatives and senators, but our mayor as well, who supports this system of care. We have a community that's very rich in agriculture and industry, Nucor being a staple community. And we're consistently listed as one of the top 100 communities to live in America. So we've got a lot to be proud of. But with that pride comes a unique set of challenges. Here in Montgomery County, we have about 72 to 74% of our kids on free and reduced lunch. Furthermore, we have about 250 kids involved with the foster care system through DCS. So rural communities do present unique challenges, and we have to be non-traditional when we're thinking through some of these problems and supporting these solutions. So in supporting our rural health systems, we have to be aware of the fact that since 2010, nearly 125 rural health hospitals have closed. Nearly 50% of those are operating at financial loss, and another third are at risk of closure. So we have to be a better partner in our community to support rural health hospitals so we don't have more OB deserts, more cardiovascular desert and trauma deserts, and further impede access to care for our community members. This is a brief snapshot of our fire department. And when we started on the track of mobile integrated health and community paramedicine, we were not looking for another thing to keep us busy. For a small rural department, we're seeing nearly 5,000 emergency 911 calls a year. That does more than enough to keep us busy. But we know being non-traditional can be a benefit, and prevention is the right way to go, and put services in place ahead of the emergency call to get better outcomes. And that's what we're working towards. So holistic care, patient-centered care, creating a community that's more resilient, that's a better place to live, work, and grow. That's what we're wanting to do with our community paramedicine program. But currently, with these challenges, we're seeing nearly 30% of the total healthcare spend is on wasted and unnecessary services. That's further making access to care a barrier. So through community paramedicine, we can put services in place more direct, more person-centered, and more beneficial to our customers. When we're looking at shared value and really breaking those barriers down and working outside of the four walls of the hospital and collaborating with non-traditional partners, it's really about that public and private partnership and how we can benefit everyone's different business model to be successful in our community and be a better partner at the fire department. Whether it's looking at workforce development and being a partner with employee assistance program, offering vaccination programs, or medication assisted therapies that we'll get into later. We want to be that partner. So mobile integrated health, community paramedicine, they're typically words that are synonymous with one another. They go hand in hand, but it's really about the quadruple aim of care and putting the needs of the patient ahead of everything else at the right time and at the right place, and at a better cost point that's going to be more beneficial. So community paramedicine is really an emerging healthcare profession that's operating in expanded roles without changing the scope. That's going to be beneficial to achieving everyone's healthcare goals. So why is this important? Why is the evolution of mobile integrated health so important? And we already touched on the healthcare spend and out of control spending. Access to physicians and physician shortages obviously is one of those. And then the uncertainties of the 1115 block grants and waiver programs and what that may mean and what that looks like from state to state. Currently, rural health systems are one of the largest employers. And as we see the further closure of rural health systems, that has a damaging impact to workforce development and health. So I think as we evolve into this, you'll see the connections of how we're going to support one another in achieving all of our goals. I think one of the things that goes overlooked in rural communities is the impact it can have on physicians and the burnout that physicians are seeing. So through community paramedicine, I think we can be better and more supportive of our physicians, get them more engaged with their patients, increase RVUs, and really create real practice transformation for our physicians. So where we reduce burnout and we improve the well-being of our physicians in our community through better linkages in care, reductions in fragmented care. And when we do this, one of the benefits we have of our individual program here is we document in our physicians' EMRs. So we operate right in Epic. Every one of our encounters goes directly to our primary care or specialty care providers in our community. That really connects them and increases their bond with their patients. And when we look at what role community paramedicine can play in your community, you're really only limited by your imagination. Currently, we're providing all these different systems to help our seniors age in place and connecting them with primary care so that they can see their 65 and over wellness visits, health education and screening, and all these services could be done in the home outside of the 65 and older wellness visits currently, the way we're set up. but it's really going to have a big impact in readmissions, the 30-day readmissions, to reduce all-cause readmissions moving forward. I'm going to play a little clip from the nightly news that aired last year, I believe, and it focuses on community paramedicine and gives you a little snapshot of what it looks like outside of a PowerPoint and providing real care in our communities, if this will load. Oh, and after this short commercial, hopefully this can be edited out.
We're actually not seeing the clip or commercial or anything. Did it open on in a different screen, possibly?
Well, I'm not sure. Hold on, technical difficulties. There we go. Are you able to see that?
I'm still seeing your PowerPoint, like the edit screen.
All right, well, we'll just close out of both of those. And possibly be able to do that for the edited version or the replay. Are we back to seeing everything?
Yes, we're back to your slides.
All right. Anyways, it was a great clip. But when we look at our difference has been non-traditional in community paramedicine, different than what other agencies and other states have really focused on. And while we recognize the fact that our most loyalist of customers attribute for about 50% of the total healthcare spend, especially in rural communities, we know that a lot of our loyal customers really just don't know how to navigate the system. They don't know how to manage their own health. And what we do here at our department that makes us pretty unique is we have our firefighter paramedics trained in motivational interviewing and brief action planning. So when we go into the home and meet with them, we can set real healthcare goals that are going to be beneficial, and we can really operate at the height of our scope as a firefighter paramedic and work as physician extenders to get real achievable outcomes. We know and recognize that this is the future of EMS. Prevention is the best way to get ahead of a lot of true healthcare issues and chronic disease. And CMS is doing a lot to support that and pilot that. And I truly believe in the next few years, we'll see this as a financially sustainable solution that every community that's going to be able to be a benefactor of. So when we look at triage, treatment, and transportation differently as an EMS provider, we'll be able to provide better in-home care through virtual care and home visits, much like we're doing here today in Crawfordsville. We're going to be able to see alternate destinations, so we're not just the most expensive taxi to the most expensive facility, which is the ER, and really reduce the cost of care and barriers at the same time to make sure that it's more person-centered and getting the better outcomes. But here in Indiana, we're not waiting on the federal government to take over. We've taken an initiative and reached out to our local senators and representatives to make sure that legislation is being put in place to allow us to be successful. Secretary Sullivan, Dr. Box, and everyone from the state on down is helping us achieve these goals. And we've seen a bipartisan support for these initiatives. With the passage of Senate Bill 498, there were 0 nay votes out of either house. And this allowed for the credentialing and reimbursement through Medicaid for community paramedicine programs. And our work with QSource, which is an independent quality assurance agency for CMS, they testified and said, if every community was to put in place in Indiana a heart failure pilot similar to ours, which had 38 patients initially enrolled, we would be able to see conservatively a $200 million cost avoidance or savings in that spend. So that's pretty impactful. And this is why we're able to be groundbreaking and leading in this progression of community paramedicine. And it's because of our unlimited scope of practice when we're working under the direction or as a physician extender through online or written protocols to deliver these different healthcare services. Currently, I'll kind of go through where we're at and where we're heading for the future with community paramedicine. And when we initially started our programs and conversations with our health system in 2013, we had to go after the low-hanging fruit, and that was heart failure. Heart failure was compounded with comorbidities, diabetes, pneumonia, COPD, but it was affecting our rural health hospital with avoidable 30-day readmissions. So that's where our program started off. In the first year, when we went through our heart failure pilot and then through chronic disease management of all those incentivized payment models for chronic disease, we're able to demonstrate a 90% or nearly 90% reduction in improper utilization of healthcare services. And 1 year post completion of our 90-day chronic disease and heart failure program, nearly 50% reduction in ER utilization and improper hospitalizations, 24 to 48 hour observation visits. So all that was proof that this concept was working for us locally. From that success, we're able to move forward with a high-risk OB program, which you may have heard of, Project Swaddle. It's been hugely successful and impactful in our community and gained a lot of support, first of its kind in the country to provide these level of services. And then success just continues to build success. So our Falls program, which was incorporated into our heart failure and chronic disease program, but further expanded to deliver immediate care and follow-up care from any of our seniors having falls in the home to really help them age in place. The overdose response program for anyone in the community dealing with SUD or substance use disorders, behavioral health crisis interventions, and currently immunizations. Now, obviously, a fire department could not do that on their own. We're able to do this level of care because we have the support of our local health hospital and the services that they offer. The other thing that we have to do when putting a program like this in place is select the right people. Customer service is number one with this. Clinical experience is very, very desired when we're providing care and working directly with physicians as extenders. So these are some of the minimums that we have in place. And if you go to the Franciscan website, Mr. Durf here, pictured, does just a fantastic testimonial of what the heart failure project meant to him and his success in staying healthy. And I just love it. He's very articulate. He's a retired school teacher, and he just has a passion. Now, all of our firefighter paramedics, to really be impactful in the home, goes through a lot of individualized training with our physicians and our nurses to make sure that we're providing the right in-home care and the right education for our patients and their family members. We don't want to confuse them and send mixed messages. So our nurses and our hospital put the patient education materials together so we're speaking the same language. We also do a lot of speaking engagements together and presenting This is Hennepin College, where a lot of our community paramedics went for their initial education. And this is a poster presentation for our heart failure project in Vegas through the UCLA Pre-Hospital Care Forum. But this is what we want to focus on, is advocacy and outreach and doing that community assessment. So we're not putting a mobile integrated health project in place that's going to be just beneficial to one siloed entity like the fire department. It has to be mutually beneficial to all community partners. And this is what we're looking to achieve. This is my dad. This is his birthday today. And when we put programs in place, we want to make sure that it's going to be a benefit to them, and it's going to be a program that we would expect our parents to receive. And that's how we move forward with customer service. So we want to improve that patient and family experience. When they're sent home and someone's discharged from the hospital, typically their spouse or significant other is not a trained physician or nurse that has that background. It's very confusing, it's overwhelming, and it's stressful. We want to reduce that stress and help them care for their loved ones and facilitate that access to care to allow our seniors to age in place or fill any gaps in care that are not being met through traditional nursing. This past week, we've received a lot of recognition, and we are the very first fire department to be included as a provider in the entire country for vaccines and immunizations. Last week, through the governor's address, he announced that teachers were going to be on the list next to be vaccinated. And as soon as we heard that, that Monday, we were in our schools vaccinating our school teachers. And I think we're just under 300 teachers vaccinated through the first week of that being open to that group. And we look at moving forward. When we initiated this program in the State Department of Health, excuse me, reached out to us and asked us to put a proposal in place of what we could do to affect immunizations moving forward and providing more health benefit to our communities. We started doing our research, and we saw in Indiana that only, I think 19% of our kindergartners due to COVID are fully immunized, and nearly 50% of our 6th and 12th graders are fully immunized. I think one of the things that we identified is this is something that we can easily do and put in place. And through the assistance of Indiana Medicaid and the State Department of Health, that's exactly what we did. We're a licensed provider. We have all of our vaccinations stored in our mobile integrated health building. And we partner with our local health department to make sure that we're putting shots in arms and getting our community healthy and back to normal. Our heart failure project and our chronic disease project to assist with 30-day avoidable readmissions still continues to be a staple for our community. We have 2 full-time community paramedics, Monday through Friday, delivering these services, providing in-home assessments, labs, patient monitoring, steady pulse assessments. That's helping not only our physicians and our health system to be more successful, but the most important, our patients. Now, as we're talking about quick response teams and being recovery oriented, back in 2017, 2018, this was a billboard that was put in place in Montgomery County, and it drew a lot of fear. It shows that Montgomery County was ranked 9th most out of 92 counties for being at risk of an opioid crisis. And it started pulling together a lot of fantastic community conversations, and really evolved to us changing the way that we operate as a fire department. Through our connections with the University of Cincinnati, we were able to make further connections with the Hamilton County Opioid Coalition. And our community stakeholders went and visited with them. We took a group of law enforcement, elected officials, our healthcare organization, to really see what a quick response team was, what it looked like, how they were operating. And we were seeing these health bulletins come across. And a week before these health bulletins were being pushed out in Cincinnati, we were seeing overdoses in our own area. This continued to have conversations. When we look at workforce development, one of the things that we were seeing an opportunity to partner with was our local industry, who is seeing more workplace injuries in Montgomery County than almost the rest of the state, and higher than other surrounding communities and states as well. And the cost of care associated with substance use disorder goes well outside of just financial costs. It's really about social determinants. More out-of-home placements with foster care, more stressed on loved ones, the spread of hepatitis and HIV due to increased drug use and substance use disorders. We saw that there was a niche maybe for us to work in this space and provide better outcomes, because typically firefighters are trusted, they're recognized, and people will share with us. Our community had a lot of stigma, and we had to have a lot of conversations. This was one of our first barriers that we had to address in our community. When we look at addictions, this is typically what is thought of when we look at opioid use disorder and substance use disorder as a whole. It's the stereotypical 20-year-old IV drug user, homeless, maybe in an alley. And at this time in the community and really across the country, as we saw the rollout of Narcan and helping communities and families care for their loved ones in crisis, there was also conversations of, excuse me, more or less 3 strikes and you're out. They really don't deserve any more help after 3 strikes and 3 overdoses. But we started changing the conversation. We said, what if this is what substance use disorder looked like? And when we start thinking about everyone wanting to care for grandma and grandpa and keeping them safe, we recognize the fact that seniors were dealing with substance use disorders. It was actually leading to falls in the home. These falls in the home were 1/4 of our department's total 911 call volume, a fall and lift assist. When we see that our senior citizens could be dealing with chronic pain issues, unrecognized withdrawals from not being able to fill their prescription medications, whether that's because of physician shortages and access to care issues, not being able to travel at night and going long distances to see their pain management specialist, or mixing pain medications with alcohol. Saw a high number of senior citizens with alcohol addictions as well. And when they're having falls in the home, it's typically repeat calls until there's a traumatic brain injury, possibly, or a hip fracture that can really increase their mortality rates. So this is one of the things that we did to assist with our quick response team. And one of the tasks that we put on them is to make sure that they were in the home immediately upon a fall, and then following up with our patients within 24 to 48 hours. Because typically if a patient's having a fall in the middle of the night, it's hard to do a home safety assessment, medication reconciliation, or perform a steady fall assessment. and then really connect them with primary care physicians ultimately if they hadn't seen them in a while. Another thing is Project Swaddle. So when we look at being a recovery-oriented community, we really need to look at a cradle-to-grave approach. Currently, our high-risk OB project sees a large number of expecting women suffering from substance use disorders. And we're able to work with our physicians that are managing moms and allowing us to do hyperemesis services in the home. We can run labs, McKenna injections for our high risk and preterm delivery risk moms, or assist with managing Subutex in the home for medication assisted therapies for moms using or past using in recovery for opioid use disorder or polypharm drug use. And when we start linking all these services and conversations together, it really had a huge impact of it's not one of them. It really could be anyone in our community, regardless of insurance, regardless of having a good job or money, good upbringing or poor upbringing. Everyone is touched by substance use disorder. And we have to realize that that's someone's daughter, son, grandma, grandpa, parent. We need to change that expectation and deliver better care, really with a servant's heart. By doing that, since 2018, we've had nearly 200 patients enrolled in our Project Swaddle program. And all, except for one, have gone to a full-term delivery at acceptable birth rates. That's hugely impactful when we look at the cost of a NICU stay and the effects that it can have on the family. When we look at bridging the gap between a patient looking for recovery and a provider, some of the things that we wanted to do with our own medication-assisted bridge program to ultimately improve survival for people dealing with OUD and SUD. These are our members of our family, they're our friends, and increase access to treatment and retention so that they can achieve long-term recovery. And all of these are really important. As a parent of past foster kids that we adopted, we want to reduce the burden on families, kids, and everyone associated with that. So this is what we had created with the assistance of a lot of people, a lot of community partners. There's really a different look at how a fire department should respond and deploy for a quick response team. So when we talk about prevention, we have a hotline, 1-800 hotline that can be accessed 24/7 to where we can get out ahead of a crisis to work with families. We go out in the community with our local health department and talk about prevention, Narcan education. We provide safe use kits for people not ready for recovery to reduce the impact or the potential impact that it could play with IV drug use, infected needles, and stuff like that. The response is immediate. We respond on our ambulances and our fire trucks. We provide Narcan to anyone on scene so that event could be avoidable in the future. We provide treatment options outside of the ER. Prior to COVID, we had taken patients directly to the ER. We've taken them directly to inpatient facilities. That's really impactful to helping people achieve long-term recovery. So this is what we do. Put full wraparound services in place no matter which route they come into our program, whether it's preventatively or during crisis. And really, we follow up on each one of our patients within 24 to 48 hours of a refusal on an overdose. We try to stay engaged with them, really building trust and capitalizing on the trust that we already have as firefighter paramedics. We also work with all of our behavioral health facilities. We're trying to work towards anyone that falls out of recovery or inpatient, outpatient services. After 30 days, we'll re-engage them. We work with our faith-based community. We know not everyone comes into recovery the same way, and we want to provide them with peer recovery and faith-based options if abstinence route is one of the ways they want to go. But I think one of the most unique things that we can do, and as far as I'm aware of, there was only one other fire department in the entire country doing this, is provide in-home medication-assisted services to reduce barriers. Now, one of the largest hurdles that we've encountered and we've heard all across the country is prescribing concerns. Physicians in the ER willingness to utilize 72-hour rules, jails, unwillingness to initiate medication-assisted therapies in the jail because of diversion. There's lack of follow-up services, connection with services, drug screen availability. And these are things that I really think a fire department can be unique in partnering with to make sure that we're addressing these concerns and taking them away. And it's really innovative leadership and medical direction offered by our local health department's medical director, Dr. Scott Douglas. He had done a lot of studying and research in providing in-home inductions for Butte for patients that are looking for this pathway to get into recovery. Whether we were looking at the Yale or Harvard protocol, we felt that this was going to be a safe and effective way. Our physician, Dr. Douglas, went ahead and immediately became data waivered. He required all of our firefighter paramedics that were going to initiate medication-assisted therapies in the home to take the 24-hour medication waiver training. And this is a protocol that he came up with for our firefighter paramedics. So if we had a patient that was going to enter into recovery on a Friday night, a weekend, a holiday, that we could fill the gap providing medication-assisted treatments from our fire trucks and ambulances through this protocol. We know that medication-assisted therapies is the gold standard of care. Buprenorphine, methadone, which we don't have access to in our rural community, could provide a lot better outcomes. But for our patients that are looking for the abstinence-based route, we recognize the damaging effects of withdrawal, and we can provide a lot of things to help them ease with that withdrawal. Zofran is one of the things that can assist with the nausea and vomiting. NSAIDs is something that we carry and has a simple protocol for on our fire trucks, and reduce the cost of care when patients maybe do not have insurance or their entitlement set up yet. We need to be able to do this in the home and bridge that gap to make them safely be able to make an appointment on a Monday or a Tuesday morning. And since we're fully engaged and integrated into our health system, we can see open appointments in our physicians' schedules to make sure we know when to link them into services. But what about relapse? And when we think about relapse, we think about how many times we should allow someone to come into our program before we throw them out. And as a fire department, I really don't think we can do that. I think relapse is part of the recovery process, and we need to change our thought process and our expectations of our patients. It's not lack of motivation, it's lack of services and support. And we can be a trusted partner to make sure that families are getting the care and support they need. And it's through non-traditional approaches. Really, whatever your community has, we can meet the patient where they're at. So whether it's in an RV, in a mobile clinic, or it's meeting them in the church, it's going to where the patients in the community needs the care and services. We've partnered to make sure that we're doing this safely and effectively, and we're getting the right legal guidance. So the Network for Public Health Law has given us some legal guidance to make sure that we're operating within the DEA's schedule and providing the medications correctly. I wouldn't say just trust me because I'm a firefighter. I don't really have a background in public health or law, but strategically, we've partnered with what I feel is to be the best of the best in all these areas to provide all of these services here for Montgomery County, and really so it could be replicated in other communities. So these people should be trusted and recognized as the best of the best, and really leading real healthcare reform through projects like ours. Now, what's next in the future steps is really taking something from a best practice and getting some academic evaluation and proving the sustainability of it and the reductions in cost of care and providing better outcomes. So that's the direction we're moving in. And I really thank everyone for logging in, learning more about what we're doing, and hopefully taking solutions back to your own community to fill gaps in care. And it's probably a little long, but I really appreciate spending the time with you today. Thank you.
Thank you so much, Paul. I know I learned a ton not being super familiar with your program, so it's just really, really interesting and great to see what you guys are doing there. I didn't have any questions come in from the Q&A or the chat. Did anybody want to chat in a question now, or did anybody want to raise their hand and ask a question verbally? Again, those options can be accessed. You hover your mouse over the screen and some options will either pop up at the bottom or there should be a drop-down menu available to you from the top of the screen. Again, just depends on what view mode your computer is in.
And I tell you, this project, this particular program is near and dear to my heart, and I am happy to have conversations offline with anybody. My contact information is there. So, I mean, I try to make myself, and my mayor cares a lot about this program. He wants to make us accessible to any community. So one of the things that we typically will do is go out and try to create stakeholder engagement and be a part of conversations in communities.
Well, that's good to know as well. Excellent. Well, still not seeing any questions come in, so just appreciate your time today. Appreciate everybody coming on. We have recorded this session. We'll have it on our YouTube by the end of the week. Just want to thank everybody for your time and attention.
Thank you.